No disclosures. So SSRIs have been around for a long time. Prozac first came out in the early 90s, and then we've had several subsequent ones that have come out during the 90s and early 2000s. And basically the way that they work in similar ways. They block the presynaptic serotonin uptake, and they have been shown to treat both depressive and anxiety symptoms. And we'll talk about kind of the efficacy in both disorders, but in general, they tend to work well for anxiety disorders in particular in younger children, and then work well for both really in the older you get, and that often we don't experience young children with a lot of depression. They may have responses to normal life events, but it's fairly rare for children under 10 to have depression in a sustained way. These are the common side effects that I think we probably are familiar with, in particular GI upset that happens at the very beginning of treatment. And sexual side effects are very common, up to 30 or more %. Lexapro is thought to have a little bit less of that, but that's something that's important to ask about in your teen patients. They can sometimes increase anxiety and some of these other symptoms that we'll talk about later. There is actually very little risk of cardiotoxicity and overdose, which especially at the time when they first came out and started to replace the tricyclics is a very beneficial quality, because tricyclics are very lethal in overdose. And it's also important to note that you can develop some symptoms of discontinuation. Sometimes this just feels like the flu just for a few days, but it can result in some of these other things too. Next slide. Before jumping in, we want to think about, what are the different treatment phases? So in the early phase, we think about trying to achieve a response and then work towards full symptomatic remission, but we're not looking for remission right out of the gate. Next is the continuation phase, where you get to a steady state dosing that is treatment to target dosing. And then you see how long you're going to continue it for. And then maintenance is really helpful for some people who find that they just end up feeling better taking an SSRI, that they have less long-term anxiety. One thing that I think we don't focus on quite enough is, how do I know when to taper down or to stop the medication? We certainly don't want people to get stuck on something unnecessarily. And I think it's important to have this in mind when you're even initiating conversation, because some families feel like, if I start this, then I'm never going to be able to stop. And that may go against their values or thinking about it. So generally speaking, you want to look at if things have been stable and there's been a certain amount of improvement for 4 to 6 months, in order to help kind of get things back on track in terms of life and functioning. That said, you also want to think about the time of year. Most young people are in some form of school. And so thinking about a lower stress time like the summertime is often a good one, although not the summer before senior year or before departure for college. And then sometimes, the patient or family really want to, and I think it's important to have that be a collaborative conversation together, and look at kind of the pros and cons, and think about a slower taper that you negotiate with them and say, these are the reasons why we would think about perhaps, slowing down this taper or actually going back to it as if new symptoms emerge. And then of course, if the side effects outweigh the benefits. Next slide. So screeners, I think this is something that I think all of us on this call do with some frequency, but these are the common screeners that we like to think about. The GAD-7 is validated down to age 10, and then the SCARED is age 8 to 18. The GAD-7 is the shorter questionnaire, and then the SCARED is longer and breaks down different anxiety subtypes, so can be useful at discerning, is this social anxiety, or is this more generalized anxiety, separation anxiety. And then for depression, I'm going to highlight the short mood and feelings questionnaire can be used for younger children, because the PHQ-9 and 2 are just validated down to age 12. And then for assessing both, you can use the RCADS, which has not as many anxiety symptoms as the SCARED, but it certainly can break down some of those different disorders. And it's also validated down to age 8. Next slide. Thinking about severity and how does that inform whether or not you choose to add in a medication to a more comprehensive treatment plan. So if there's mild symptoms, meaning just 0 to 1 area of impairment, and then that the impairment is not constant, but is more on a weekly basis. Moderate is 1 or 2 impairments and more on a daily basis, possibly with another co-occurring condition or a history of suicidal ideation, although not active. And then severe is, more impairment, more comorbidities, and then a more recent history of suicidality and or attempts, or indicators of more severe mental illness like significant substance use, psychosis. So what are some general guidelines? I think it's important to note that most SSRIs, because they do have a similar mechanism of action, their efficacy is generally similar. Some studies will show some treatment differences, and we'll talk a little bit about how those studies were done and how that has informed the literature and FDA approvals. But to just note that in general, they all work in a similar way and tend to be similarly efficacious. And there's not one that tends to work faster than another necessarily. So just to think about that. And then the one that you choose is really based on, perhaps a history of past response in that individual, or the potential side effect profile and that being helpful for the patient, or other existing medical conditions and whether there are interactions with other medications. There's usually some time between initiation and appreciating a therapeutic response. And that said, certainly clinically have seen responses in a shorter amount of time than this 3 to 6 weeks, but that is a general rule of thumb. And that you usually see some level of response and or partial remission by week 4 if you've got the right medication and at the right dose. If you are really not seeing any improvement after 8 weeks at an adequate dose, then it's important to re-examine this and switch to another agent, because it may be that the cytochrome P450 in this individual is metabolizing this medication either at a slower rate or at a faster rate, and so that this particular choice is not, the right one for this person. There tends to be kind of greater benefit in anxiety than in depression, in particular in younger children, and then the risk of side effects is often inversely proportional to age, and I think that's something important to consider. Next. So when you're having anxiety symptoms present, you want to assess and screen with the screeners that we've talked about, and ideally arrive at a diagnosis, and then assess, whether this is in more of the mild range or more of the moderate to severe. For more milder presentations, you do want to look at more just psychoeducation. It really is so powerful to just share with families, we think that this is separation anxiety, and this is really normal to happen, especially in light of the past year and all families being kind of clustered together. And now, we're returning to what feels like a new-ish environment in school. And so this is normal, and with some scaffolded support, we can get back on track. And also looking at other factors like sleep and eating and exercise and social connection that can help to decrease anxiety. And then to also consider therapy if this isn't responding to that psychoeducation. For more moderate to severe symptoms, you can think about, first-line treatment, which for most anxiety disorders, cognitive behavioral therapy is the most evidence-based type of treatment that really focuses on identifying how your thoughts, feelings, behaviors, and bodily sensations all relate and connect, and and can be really helpful. However, if with CBT, either there's no response or someone is so anxious that they can't actually do the behavioral interventions, then that's when you think about a medication. Or if there's really significant impairment, then you can go ahead and think about an SSRI earlier. In terms of patients being suicidal or psychotic or with significant substance use, or if they've failed to SSRIs, then you want to think about referring. Next slide, please. So when to prescribe in primary care? When there's been ongoing mild anxiety that progresses, if there's really significant impairment, for example, I would not necessarily wait to engage in CBT if someone is really not able to get out of the house to go to school when that's what's expected, or if there's been a partial response to therapy and support. And then, of course, if the parent and the child or teen agree. And then I think this may go without saying, because most people, when we take calls, they say, I really know this family. I feel like, they're going to follow up. I know this, I can monitor. But you do want to think about that, because with intermittent adherence, there can be more risks than not prescribing at all. And that is because of the discontinuation and withdrawal side effects that you can get with SSRIs, in particular shorter acting ones. And so, we think that there's the potential for some worsening before things actually improve. And if you're constantly kind of having very uneven blood levels of this, then you may be feeling worse. And then ideally, if you can consult and collaborate. So these are the most commonly used ones, both the generic name and the trade name, and then the formulations that they come in. As you can see, they all come in both tabs and liquids. I think a lot of people are not necessarily aware of it coming in liquid form. I will say, though, that this is not bubblegum or cherry flavored the way that antibiotics are. They generally do not taste good. And so I personally, like to recommend crushing it up and then putting it in some yogurt or Nutella or whatever works. But the liquids, I will say, really generally don't taste that great. These are common starting doses and then titration doses. And there is a lot of evidence to show that the old adage of start low and go slow, the reason that works is that you really help to prevent any major side effects, in particular in the beginning, the GI upset that can happen. If you take it with food, that can really help to prevent the GI upset that is common in the first week or two. And so sometimes, like, the only, predictable meal for teenagers especially can be dinner. It's often, I just rolled out of bed and started class, and then I forgot to eat lunch, or I didn't have time. So if it needs to be with dinner, especially during the first couple of weeks, then, to talk that through at the beginning, because if you don't do that, and then there's any ambivalence about the medication, or even if there's not, and you're not experiencing any benefits and you feel sick, why would you keep taking it? A word about the FDA approval. So these, you can see here that the meds that are approved for anxiety disorders, the only one that's actually no longer classified as an anxiety disorder, but rather its own separate thing, is OCD. And the reason that it got approved for OCD and not other types of anxiety disorders is because of the way that the FDA approval process was revised in the late 90s and early 2000s. And it was easier to demonstrate an effect in OCD than it was in other types of anxiety disorders. And then the only two for depression are Prozac above age 8 and Lexapro above age 12. Next slide. So here's a little bit about the half-lives, and I think this is important to keep in mind that, generally speaking, most of these have, about a 1-day half-life, other than Luvox, which may require twice-a-day dosing, which often can be, fairly inconvenient. And then Prozac has this much longer half-life. So this is really the only one that you can do where there's no withdrawal. So if you're concerned about consistent adherence, you won't experience that physical withdrawal with Prozac. If anything, this can feel a little bit activating. And with that, it can feel like it's increasing energy levels. So for someone who has kind of a more shut down, more psychomotor retardation type of presentation, this one can be helpful for that type of presentation. Because of that, it may be better to do it in the morning. That said, unless they're having trouble falling asleep and they're not eating until dinner, you can still do it in the evenings. And this one does have a high level of cytochrome P450 drug-drug interaction. Zoloft, if anything, may be sedating. It's not for most people, but it might be. And so with that, you may want to consider doing it in the evenings. This one I really like in particular for younger kids because it tends to be fairly well tolerated and really helps with different types of anxiety disorders. Interestingly, it does have a very mild dopamine blocking effect. And so I've had a couple of circumstances of, in one instance, a person ended up taking too much and actually got some extrapyramidal dystonic symptoms. So that's important to keep in mind. And then Lexapro can be usually more energy neutral, but may be activating or sedating for some people. It's thought to have less drug-drug interactions and slightly less sexual side effects. And then these others, so Luvox has an indication in pediatric OCD, and generally it's often only used for that, although it does look like, based on a very recent analysis, that it may have some anti-inflammatory properties that may be helpful in long COVID. And then Celexa is very close in terms of its chemical structure to Lexapro, and it can also have less drug interactions. Paxil, I honestly can't think of anyone I've ever started on Paxil because the FDA warning came out when I was in close to the end of my training, and I've just never initiated it. It's a pretty dirty drug. It hits a lot of different receptors and has a lot of drug-drug interactions, and has a very high risk of weight gain. It's generally very sedating, and it's also harder to come off of than some others. Next slide. So how do we think about cross tapering when either a medication is not working or there are problematic side effects? There are a couple of different approaches, and one is that you just stop one medication on one day and then start a new one at a slightly lower dose on the next day and try to quickly get back up to what would be an equivalent milligram per milligram dose. Generally, Lexapro and milligram per milligram comparison is not the same. So there is milligram per milligram, Lexapro is about 2 to 4 times stronger than Prozac. So that means that Lexapro 5 to maybe 10 milligrams is the equivalent of Prozac 20. So just to keep that in mind. Also, you have to consider that with Prozac, it is going to take, that 4 to 6 or 7 days to get to 50% less. And so you have to think about that before you start a new medication. And then the other way to do it is to go slowly down and basically cut the dose in half once a week to get to a stopping point. And then at the halfway point of that going down, then you start a new one and you go up, as seen by the arrows here. I tend to prefer that second approach. Clinically, I've had some kind of greater challenges in terms of responses and side effects with doing just the switch more quickly. And doing it in this way, also when you're thinking about coming off, helps to prevent that discontinuation syndrome that we were talking about. Next slide. So these are some common side effects, and the GI distress and headaches typically resolve after a week or two. Again, this can be prevented by starting at a low dose, ensuring good POs, both food and water, and then appetite change. Thinking about healthy nutrition. There can be weight gain associated with these medications, and in general, the younger the child, the more vulnerable they may be to that weight gain. Typically in adults, SSRIs, they contribute to kind of a single digit amount of weight gain, but in younger children have certainly seen higher weight gain in vulnerable individuals. It's not that common, but it certainly can happen. It's something important to track. And then the diaphoresis or sweating is something that can happen. And I think as long as it's not interfering, it's just something to provide some reassurance about. And we're going to talk about activation in a moment, but the platelet dysfunction it actually inhibits platelet aggregation. And so you may get decreased bleeding times, and this may appear like bruising, or it may come up around prep for surgery. And it's something to look at. There isn't really any clear treatment for this, and it may happen with a different SSRI as well. Next. So activation is something that it's important to be aware of. The prevalence, depending on what study you look at, can be anywhere between 4% to upwards of 50%. And it's a real continuum of different things, but basically it can happen in one or more of these different domains. So there can be increased irritability. There can be akathisia, or just a feeling of restlessness. You may notice new foot tapping or moving or things like that. More disinhibited behavior, loose and goofy, things that look like mania, that include difficulty sleeping, but it is not mania in the true sense of the word. And then urges for self-harm that are related to this. But really thinking about this as a generally physical thing that ends up showing up like an emotional one. And you want to think about decreasing, switching, or stopping. But if someone does have akathisia and otherwise this is helpful, you can do a beta blocker. Next. So just to tease apart the difference between behavioral activation and bipolar switching, this is something that tends to happen most commonly in the days to weeks after starting and or increasing the dose. And there is not a significant change in mood, but it may look like nervousness or irritability or akathisia. And this does not mean that someone is at greater risk of developing bipolar disorder, and it doesn't mean that someone has become manic. And then in contrast, bipolar switching tends to occur later, and it actually may not stop with discontinuing the medication. There can be, mood changes that look anywhere from depressed to anxious to manic or hypomanic. And this is usually in someone who is genetically vulnerable to developing bipolar disorder. Next slide. So this is an FDA warning. I think that we're all fairly familiar with this, but I want to highlight that the highest risk is in the first 9 days of treatment, and is higher when you start with high doses and or when you go up quickly. And it's something that you look for in the first 1 to 3 months of treatment. And then after that, if you're seeing anything that remotely feels like this, it is likely not from the medication. I can honestly say, with trying to practice conservatively and go slowly enough, that that I have seen this twice with Strattera and once with an SSRI. Next. So here are just some pearls in talking with parents, and these will be in the handout that we share. And so these are just some common questions that we get. Will this make my child like a zombie or change their personality? What does the SSRI warning mean? We'll pause here. I can't remember if there was one more slide after this, but
just the references.
Yeah, I know we're at time, so can pause for maybe one question.
I see Lori has a question.
Yeah, I had a question. If I had this phone call yesterday with a 21-year-old who had just gone up on her dose of Prozac and was feeling incredibly anxious, was basically having panic attacks. She also said her heart rate was like in the 130s and 140s. So, but she also, I mean, I don't know if that was her anxiety doing it or not. So I'm dropping her dose down. But one, I mean, when do you put them on propranolol? And two, do you see a higher heart rate in that situation?
No. So what we didn't talk about, there's a more uncommon risk of serotonin syndrome,
Yeah.
and that is usually accompanied by other, symptoms, including clonus and things like that. What you're describing makes me think that this is more likely increased anxiety, and you certainly can do, a beta blocker to help manage anxiety as an indication for performance anxiety. And I love beta blockers to help kind of mitigate stress response and to decrease social anxiety.
But decreasing her dose is the right thing to do too, right?
Yeah, and then checking back. But I would wonder with the decrease how much these things improve, unless her circumstances become less stressful and then she's not feeling this way.
Okay.
There was one more question. It was about serotonin syndrome. When to worry about it? What can precipitate it?
Yeah, it can be, it generally happens when the net effective dose is high, and it's more likely to happen at the beginning of treatment, or when there's a significant increase, or when you add in other serotonergic agents like atypical antipsychotics or lithium. And so I think, looking for any kind of like muscle rigidity can be some subtler symptoms, and then you have these vital sign changes and some of the other symptoms. But generally, if you start low and go slow, even if someone is a slow metabolizer, then it'll declare itself a little bit more. What's more likely is like the activation.
Wonderful. Thank you so much. So we're going to go ahead and switch gears and do our case. And today we have Darcy, who's going to be presenting our case for